If the figures can be believed, there are a lot of unhappy people out there. Up to 80% of us, in some studies at least, have reported experiencing a mood disorder, such as depression, at some stage in our lives. Here with me on the couch to discuss the issue is Professor of Psychiatry Gordon Parker. Welcome, Gordon, and thank you for being here.
Well, thanks, Steve. It's very appropriate to be on a couch as a psychiatrist.
It certainly is. Now, let's get to some of the issues around depression and the treatment of depression, especially your research, in a minute. But first up, tell us, how did you first become involved in psychiatry? Why did you want to become a psychiatrist?
Basically, the way in which my family was set up, I was genetically programmed to do medicine and surgery. Two of Sydney's leading surgeons were my godfathers, so there was a clear message of what I should do in life. The problem was when I had an existential moment in Prince Henry Hospital training in surgery, I realised that I was technically incompetent, and that's a bit of a problem. So surgery wasn't for me. The second failed career that I started, and I started it as a senior medical student, was as a writer. And I had a very heady period of time writing for the Mavis Bramston show and for Oz magazine. And for a while I actually worked with Peter Pockley on the Science Show with the ABC, and I had a book of fiction published, and I really thought that I was going to be a writer. But that came to a fairly abrupt end, although I did maintain a writing trajectory for another 10 years. So I'd failed at surgery, I was failing as a writer, and a couple of friends took me out and they said, "We think you should do psychiatry." So I said, "Thank you very much," but didn't ask the question why. I suspect the reasons were that I've always been a people person. I love listening to people's stories. I like appreciating the richness of life. Psychiatry is like going to a good Chekhov play. You see people at their worst, and at their worst they're usually at their best. So I think there was something in me that those people had seen. And once I was in psychiatry, I was like a pig in mud. And there wouldn't be a week go by that I don't hear an inspiring story or I learn something. So I basically regard myself as a reasonably creative person, and psychiatry has allowed me that opportunity within medicine to be very, very creative.
Now look, as we said before, those statistics, you know, up to 80% of us having experienced a mood disorder at some stage in our life, they're pretty extraordinary statistics. You're on record as being a bit sceptical about those statistics. Can you explain why?
Until the first antidepressant was discovered in the 50s, it was basically thought there weren't that many depressed people around, because at that stage depression was the biological disease melancholia. And when the first antidepressant was discovered in the 50s, the manufacturer didn't think there were enough people to make any money and they weren't going to release it. So we probably focused on one type of depression until the last 3 decades. And we focused on the biological type, melancholia. But what we've seen since then, in the 80s, depressions were defined as major and minor. And since then they've moved on to subclinical. And so they've taken depression as the disease, and then they've dropped the criteria and the definition down, so that in fact we've now blurred the boundary between what you could reasonably see as clinical depression and what is basically normal sadness and unhappiness that we all experience. And that concerns me. So I don't think the 80% figure for clinical depression is valid at all.
Now, you're saying that this model that that professionals are using in both the diagnosis and treatment is what is to blame here. Where does that model come from?
It largely comes from the DSM-3 model, where they moved.
The DSM is
the Diagnostic and Statistic Manual, which is published by the American Psychiatric Association. It's really the Bible for psychiatric diagnoses. And in 1980, they moved away from subtyping depression to this dimensional model of having major and minor. What's really interesting is the architect of DSM-3, Bob Spitzer, has written recently in a book that's criticising where we've got in recent years and said, we got it wrong. But unfortunately, so much momentum has been picked up by this very simple model. It sounds good to have major depression. I mean, judges say, well, a person's got major depression, that's got a lot of gravitas, must be very, very significant. But when you actually look at the criteria for major depression, it's a bit like a psychological sneeze. And then underneath that, there are minor depressions. And then underneath that, they've even got subclinical depressions. Now, when I was training, my boss said, if it's subclinical, it can't exist. And yet we've got this extension in extremis where we're starting to get a little bit ridiculous.
And therefore those statistics like 80%
Exactly
are
right.
cropping up.
Exactly right.
Now, this diagnostic manual and the model that you're talking about, it's created problems not only for diagnosis but also for treatment. And this has highlighted an area that is becoming you're becoming very passionate about, which is the condition of melancholia, which you talked about before, and the treatment of melancholia. Can you explain the problem with that?
Well, for a long period of time, melancholy was viewed as something that was of a disease nature, without doubt. And in fact, you read descriptions by Hippocrates. It was a disease. You read St. Paul to the Corinthians that describes there this type of depression that came from God, because it wasn't in response to life stresses. So it was this view that the person must be inheriting a problem, and humoral theories were invoked and so on and so forth. So there was this view of melancholia versus the rest of a whole set of other depressive disorders, which we can loosely call non-melancholic. And that persisted basically up to the 1980s, when the DSM model came in and said, let's reject melancholia and let's just call depression major and minor. And so then melancholia effectively got marginalised. And it is, in my view, still a categorical condition that affects probably about 3 to 4% of the population, is an extremely severe condition, because basically during that state people lose the light in their eyes, their concentration goes out the window, it's hard to get out of bed, there's huge disability, they can't get any pleasure out of life. It is very, very physical, and this is the one where the neurocircuits truly are turned off. And here medication is highly effective. It's a very rare individual that we can't get out of melancholia. But if you put melancholia in with all the other depressions and just call it major depression, then your capacity to work out what are the best treatments and also to work out the best causes then becomes limited. And these days we've got very elegant, genetic paradigms, neuroimaging paradigms. But if melancholia is merged in with all the other depressions, then you lose signals.
And people fall through the cracks.
They fall through the cracks clinically. So we see lots of people who have true melancholia who've been seeing somebody in psychotherapy for 3 years or 5 years and nothing's touched the side. And conversely, we see people with a non-melancholic disorder who might respond to common sense counselling being filled to the gills with antidepressants and antipsychotics and courses of ECT. So that's the problem of over-treatment and under-treatment.
And for someone with melancholia not receiving the appropriate treatment, not receiving an antidepressant, is a very serious thing, isn't it?
A very serious thing. In the old days, before there were any physical treatment, somebody with melancholia would be out of action in the world for 6 months to 30 years. The severe ones would get admitted to hospital and everything. There's nothing we could do, and there weren't any things you could do. But one day, after 5 years or 10 years, the person would just say, I'm feeling okay, and walk out. So there was always this capacity for spontaneous remission. Then when the antidepressants came in, we suddenly had a treatment in the 50s. And these days, with the right antidepressant medications, we can get most people out of melancholia in 6 weeks. And sometimes with some of the faster interactions that we use, we can actually get people out of melancholia in 2 weeks. This is fantastic. And this is what probably excites me most in psychiatry, the capacity to have strategies to help people who are really doing it so hard and at such a high risk of killing themselves.
And there is a high suicide risk for people with...
Extremely high. It's actually even higher in people with bipolar disorder because they have highs as well as melancholic episodes. And they enjoy the high, and then when they realise they're going back into that dark space again, they can often say, I don't want to go there again. So the highest suicide rate is with the bipolar people who are about to slide into melancholia, and then that's followed by people who just have episodes of melancholia only.
So what needs to happen?
I think the first thing is to challenge the model that is out there, which just views depression as varying along a severity. Obviously we're challenging it, and what's exciting is that we're now seeing many senior people in America also challenging the DSM model. But we're making a significant contribution to that process. From our research side, we're very interested in actually demonstrating unequivocally for the first time that certain treatments are more effective than other treatments for melancholia.
And there's studies that are being undertaken at the Black Dog?
Yes, at the Black Dog we've got a major study looking at melancholia and comparing 3 treatments that are all held to be effective. So no one gets a placebo. And we're looking for people that will accept random assignment to these 3 different treatments. We hope that the treatments will get them out of the episodes. But if those treatments don't, at the end of the 12-week period, or if we're really worried during the trial, we'll take them out, and then we will treat them as part of the institute out of the episode. So there's a very strong clinical commitment.
And will the results of these studies go some way to influencing the attitudes toward this model?
I'd certainly hope so. We've mounted a very big challenge to the DSM system about the need to bring back melancholia as a separate subtype. And I've been asked to draw up criteria, and we've got a paper that will come out in the American Journal of Psychiatry. And what's exciting is the submission that we wrote came from 18 senior psychiatrists from 5 different parts of the world. So I think we're making an impact and a challenge. And while we've been a minority view for 10 years, I think we're starting to pull ahead as a consequence of people increasingly recognising the limitations, the pretty dumb model that's been around for the last 30 years.
I remember the Dalai Lama being interviewed and asked what the secret to happiness was, and he answered quite famously, 9 hours sleep a night. What would you answer to that? What, from your experience, is the secret to happiness? What
makes me happy these days, I guess, is it's actually not so much getting a research grant or getting a paper accepted. At the end of the day, if I feel that there's a patient who I've been worried about and they're now pulling ahead and they're coming out of that terrible zone, when I drive home, that's actually the issue that probably presses my buttons these days, in the sense of seeing, okay, well, I'm glad I stayed in psychiatry, and this is a good area to work in, because we truly can help people.
And perhaps also getting 9 hours sleep a night?
I can't think when I last did that. And the Dalai Lama, of course, doesn't get 9 hours sleep at all.
Okay. All right. Thank you very much for your time today.
Thank you, Steve.